So, hi everyone, how are you doing? Salvatore Caravella, pediatrician and Chief Quality Officer at Allied Physicians Group. Thank you all for participating this evening. This is going to be an amazing lecture by Dr. Robert Marion. Some cutting edge stuff is going to occur this evening, so hopefully you'll enjoy. But just a little bit of housekeeping as well. There will be CME awarded. You will receive an email from Allied directly. It'll have a link, and on that link you click the link, fill out the paperwork that you'll need to do, and your CME will be rewarded. So I would like to pass this over to Dr. Fatima May so we can get on with our program. Dr. May?
Thank you. So no housekeeping from me, but I do have the honor of introducing Dr. Robert Marion. Dr. Marion is a professor of pediatrics, obstetrics and gynecology, and women's health at the Albert Einstein College of Medicine, my alma mater. He is Chief Emeritus of the Divisions of Pediatric Genetic Medicine and of Developmental Medicine at the Children's Hospital at Montefiore, and he's Director Emeritus of Einstein's Rose F. Kennedy University Center for Excellence in Developmental Disabilities and of its Children's Evaluation and Rehab Center that many of us know as CERC. From 1987 through 2010, he served as Director of Genetics at Blythedale Children's Hospital in Valhalla, New York, and he has taught at the Joan H. Marks Graduate Program at Sarah Lawrence College since 1980 and has served the program in multiple roles, including as a member of its admissions committee. In 1979, a graduate of Einstein, Dr. Marion did his internship in pediatrics at Tufts Medical Center in Boston. For many reasons, he then decided to return to Einstein for his residency in pediatrics at Jacobi and fellowship in medical genetics at Einstein's affiliated hospitals. He's been a faculty member at Einstein since 1984. From 2002 until 2007, he served as co-director of the medical student education for Einstein's Department of Pediatrics, and he has been co-chair of Einstein's Committee on Admissions since 1990. I had the privilege of working with Dr. Marion in medical student education for several years. Dr. Marion's clinical and research interests include the natural history and genetic basis of multiple malformation syndromes. At Blythedale, he served as medical director of the Einstein Montefiore Spina Bifida Clinic for 25 years. He is a founder and director and co-director of Montefiore's Regional Williams Syndrome Center, where I have sent my patients, CardioGenetics Clinic that we will hear about tonight, ImmunoGenetics Clinic, and Dermatology Genetics Clinic. He has published extensively in the medical literature in these areas, and in addition is the author of 7 fiction and nonfiction books, including The Intern Blues, The Boy Who Felt No Pain, winner of a Christopher Award, Learning to Play God, and Genetics Rounds, A Doctor's Life in the Field That Revolutionized Medicine. Dr. Marion's efforts as a teacher have received recognition numerous times. He is the recipient of Einstein's Samuel Rosen Award for Excellence in Medical Student Teaching, selected by medical students. I was probably one of them. And the Alumni Association Lifetime Service Award. He is also the winner of the Lewis Fraud Award for Residency Education, which I also probably voted for him, and the Obrinsky Award for Excellence in Medical Student Teaching in the Department of Pediatrics. In May 2015, he received the Exceptional Commitment to Teaching Award from the Joan H. Marks Graduate Program in Human Genetics at Sarah Lawrence College. In May 2016, he was awarded a Lifetime Achievement Award for Teaching from Einstein. A resident of Westchester County, he lives with his wife, Beth, and is the father of 3 children and the grandfather to 3. I can tell you on a personal note, it's been my privilege to know and learn from Dr. Marion from my days at Einstein as a student, during my Jacobi Montefiore residency, and I'm old enough to still call it the Jacobi Montefiore residency, where he was my attending not once, but twice, and as a young attending teaching medical students at Flushing Hospital. My partners, the Jennifers, Rich and Cher, will echo all of these comments that I've made. He was a wonderful teacher that truly affected the 3 of us in our paths to becoming the pediatricians that we are. We are very, very lucky to have you speaking to us today. And with that, please, we welcome you, Dr. Marion.
Oh, yes.
I think you're on mute, Dr. Marion.
Okay. Thank you, Fatima, and thanks for that build up. There's no way that I can possibly live up to everything that you've said. And it was my privilege to work with you in medical student education for those years. So so thank you for saying all that. And so I'm going to talk tonight about the future, but the future is really here. And you might be thinking this is science fiction stuff. This isn't stuff that we as pediatricians need to know about. But in fact, you do, and you're going to need to know this more and more as time passes. So I'm going to talk about precision medicine, and I'm going to try to do it by telling stories from our sudden death clinic or our clinic for the suddenly dead. We have difficulty trying to come up with a name for this activity. I think you've all received a book that I'm working on, kind of a work in progress about our clinic, and a couple of the essays that are in that selection I'm going to talk about today. So if you've read that, you'll have more details than I'm actually going to talk about. So first, I want you to know that when I was a medical student or just finishing my medical school education, genetics was a small, insignificant subspecialty of pediatrics. And that's what I was looking for. I was looking for something small and insignificant to spend my life in. But what's happened is amazing. Over time, the whole scenario has changed. And so today, pediatrics is really a small, insignificant subspecialty of genetics. You can't practice medicine today without having some background in genetics. Every specialist is now sending off genetic testing, and that's going to become more and more the case as time goes on. So genetics has infiltrated really into every aspect of medicine. What I'd like to do in the next 45 minutes or so is to describe the concept of precision medicine, which is also known as personalized genomic medicine. So I'm going to probably use these two terms interchangeably. I'll describe how precision medicine has changed the practice of medicine, and I'll use cases from our clinic to illustrate a lot of these points. So first, a definition. What is precision medicine? What am I talking about? It's an approach to patient care that uses information about the patient's genetic background and the environment in which that person's genes are expressed to develop a plan of treatment and prevention for that individual. So you all know this is how medicine has been practiced for years and years. Conventional medicine waits for a patient to develop symptoms and signs and then provides treatment. The kid starts to wheeze. You say, aha, this child has reactive airway disease or asthma, and you jump into action and try to get that kid's airway open again. What happens in precision medicine is to shift this paradigm, allowing us to recognize that individuals are predisposed to develop these conditions and try to take steps to prevent that from occurring. So what if we knew that this child was prone to develop a reactive airway disease seasonally from the time that he or she is an infant, and that his or her airway is going to respond to one particular medicine, but not to another medicine? By doing that, you really have an idea of how to treat this child before the child actually gets sick. So I want to first start by showing you some evidence that the age of personalized medicine or precision medicine is upon us. And this is case one of this talk. It's my mother-in-law. So my mother-in-law, Mildred, at this time was 94 years old. She's in excellent health. She's now 96. She's in excellent health, but she had an upper respiratory infection with a cough that was productive of yellow sputum. So she went to visit her primary care provider, and he diagnosed bronchitis and started her on an antibiotic. But as part of the workup, without telling her, without getting her consent, he ordered a genetic test to assess her risk of coronary artery disease. I have to think what happened was that he received a visit from a lab, a commercial lab, and was told that we have this test that will predict who's going to die of a heart attack. And if you don't do this test and the patient does die of a heart attack, you can get sued. So he started doing this test on everybody who came into his office. And in my mother-in-law's case, the results of this test revealed that she had a genetic polymorphism on chromosome 9 that was believed to predispose people to coronary artery disease. So she took the antibiotics that had been prescribed for her. She got better. She came for a follow-up visit 3 or 4 weeks later. And at the time of the follow-up visit, the physician agreed that she had gotten better, she'd gotten over her infection, but he told her that she had this predisposition to coronary artery disease and asked if she would like him to start her on a statin for her underlying heart condition. She was smart enough to decline, noting to him that she was asymptomatic and clinically fine. So what do we learn from my mother-in-law's case? Well, the first thing is that precision medicine has reached the general practitioner, that next generation genetic sequencing, which I'll define in the next slide, has infiltrated all fields of medicine, including primary care. And that when used appropriately, genetic tests can be powerful tools in caring for patients, but the provider who orders and interprets the test has to understand the implication of the results that he or she receives. And finally, used correctly, precision medicine can and does save lives, but used incorrectly, it can be dangerous and an enormous waste of money. So let me tell you a little about next-gen sequencing. This is next-gen sequencing offers the possibility of mapping the entire genome at an affordable cost. So you know that the Human Genome Project sequenced the entire human genome. It took about 15 years and a cost of $3 billion. But that procedure, sequencing the human genome, has now been cut to a shorter period of time and at a much lower expense, so that actually today we are able to send off blood on a patient and do a whole genome sequencing, the same thing that was the result of the Human Genome Project. It now costs a few $1,000s, but within the next few years, the cost will come to under $1,000 to sequence the entire genome of a child. And so the question is, once the cost has come down, are we going to be doing whole genome sequencing on infants in the nursery as their newborn screening? There are ethical issues involved in this that have to be sorted out, but the fact is the technology is already there to allow this to happen. What'll happen if that occurs is that by the time the kid leaves the nursery or soon after that, we will basically know that child's entire medical course, his entire medical history. We will be able to predict it because we'll know what changes in what genes or what sequences in the genome this child has and what diseases are associated with that. So I've been talking about this, by the way, since about 2000. I've been teaching medical students about it, and it seemed crazy when I started talking about this, but actually the technology, the time frame is actually right on target. These numbers that I'm talking about, 2025 for whole genome sequencing in newborn screening, is really possible. So let me tell you how, stories about how precision medicine can work in today's environment. And to do this, I want to tell you a little about the Montefiore Einstein CardioGenetics Clinic. So the clinic was founded in 2006. This is how it got started. Well, it's a long story about how we actually came together, but on a Friday morning, I think it was in the summer, Tom McDonald, an adult cardiologist who specialized in electrophysiology, Christine Walsh, a pediatric cardiologist who I've worked with for years and years, who's also an electrophysiologist, and I, a medical geneticist, came together on the 5th floor of the Children's Hospital to start seeing families that had inherited disorders of the cardiovascular system. So these were patients that had cardiac rhythm disorders, they had cardiomyopathies, they had aortopathies, diseases of the aorta, and we started seeing patients together. We didn't tell anybody, by the way, we just started seeing patients. And we got a lot of pushback from the administration, but they realized that really a pretty good thing. And so we were allowed to continue it. So we assembled for this clinic a multidisciplinary team, including those primary team members that I talked about, plus a genetic counselor who works as the coordinator of the clinic. And we have additional team members for reasons that will become clear in a little while: a social worker, a psychologist and bereavement counselor, an ethicist, and others, including basic scientists. Attorneys are sometimes needed. And most importantly, I think, or equally importantly, trainees, people, residents, medical students, fellows from these different disciplines coming to see how this is done. And this is an early picture of our clinic. We have a geneticist, a pediatric cardiologist, an adult cardiology fellow, a geneticist. You have to have a geneticist every 3rd or 4th person, an adult cardiologist, a nurse practitioner, a genetics fellow. And again, we came together and started seeing patients. So we also established an important connection with the New York City Office of Chief Medical Examiner. This is a pretty amazing story, I think. So the New York City Office of Chief Medical Examiner established a molecular genetics lab in their building in 2001. That year, it was not just a coincidence that they chose that year to open this lab. After 9/11, there was a real problem. There were a lot of real problems, but one of the problems was they were identifying body parts in the wreckage, and had to try to identify who those body parts belonged to so that families could get some closure. The chief medical examiner, Charles Hirsch, recognized the fact that it would be more expensive to send out all this material to an outside lab than to do it in-house. And so with that in mind, he established this laboratory. This may be the only good thing that came out of 9/11. But the fact is the lab opened, and by about 2004, 2005, the need to identify body parts had waned, and they started using the lab technology to perform genetic testing on decedents, people who had died, whose cause of death was not evident. So these were people typically who died suddenly without any preceding medical problems, and in whom autopsies failed to reveal a cause of death. In 2007, as a result of the next case I'm going to talk to you about, Tom McDonald reached out to Ying Tang, who is the director of the lab, he brought to her attention the importance of doing the testing and following up with families. And so from that point on, when abnormalities were identified in the genetic testing in decedents, the medical examiner's office had no ability to counsel the living. These conditions, as you'll hear, are autosomal dominantly inherited. So if a parent dies suddenly, his or her children may be at risk for developing the same cardiac problem. So as a result of that, when the lab began to identify mutations in genes known to be associated with cardiac rhythm disorders or cardiomyopathies or other conditions, the lab began referring the families of decedents to us for evaluation. And to kind of cement this, in 2016, the Office of Chief Medical Examiner hired a certified genetic counselor to interact with these families, and the counselor began attending our clinic. So we have kind of a seamless transition from the medical examiner's office to our clinic. By the way, the New York City Office of Chief Medical Examiner is the only medical examiner in the world that has this setup. So it's really a very special thing. So as a result, let me tell you about case 2, which is Miss V. This was our first joint case. This is the case that brought the medical examiner's office and us together. And this is one of the essays that appears in the handout that I sent out. So Miss V was a 24-year-old Latino woman who'd been in excellent health, but was found dead by her son on the bathroom floor one night when he had to get up to pee. She was found. He got his father. The father came and started to resuscitate him. EMS was called. They arrived within 10 minutes. They began CPR. They transported her to the emergency room. Resuscitation failed, however, and she was declared dead in the emergency room. She was a medical examiner's case. An autopsy performed revealed the presence of alcohol and cocaine in her body fluids. And so the medical examiner signed her out, cause of death, as a drug overdose. But there was a backstory. A month prior to her death, Miss V had been seen in the emergency room at Montefiore for an episode of syncope. She got worked up. They did an EKG, which happened to be read by Dr. McDonald, and it revealed that she had a prolonged QT interval. As a result of this, she was referred to cardiology for possible long QT syndrome, and the evaluation revealed a positive family history. She had an uncle who had died suddenly of unknown causes, and no autopsy was done. She had a normal physical exam, but her ECG did reveal a persistent long QT interval. She had a normal echo. She had essentially a normal Holter monitor. She had a stress test, which also demonstrated the presence of the prolonged QT interval. So based on the history and the EP studies, she was referred to us for genetic evaluation. However, she died between the time that the cardiology evaluation was done and the time that she was due to come to our appointment. So Tom spoke to Dr. Tang. Dr. Tang got DNA from the decedent and performed the the sudden death genetic panel, looking at 96 genes, sequencing 96 genes that are known to be associated with sudden death. She found that Miss V had a heterozygous mutation, was heterozygous for a pathogenic variant in KCNQ1. So KCNQ1 is the gene known to be associated with long QT syndrome type 1. So a couple of things I want to tell you about here. We're trying to get away from using the term mutation. So you'll hear geneticists talk about pathogenic variants. When you hear the term pathogenic variants, think mutation. Mutation has a bad connotation, so that's why that's happened. And the second point is that when we talk about genes that are associated with the formation of cardiac channels, which I'll tell you about in a minute, the first letter of the gene tells you which channel you're dealing with. So KCNQ1 is a gene that encodes a protein that forms the potassium ion, right? Because K is the genetic symbol, is the chemical symbol for potassium. Just a quick overview of cardiac channelopathies. So the way that the heartbeat moves from one cell to the next is through the fact that action potentials are created by the movement of ions in and out of cells, in and out of the cardiac cells. And that movement of ions produces the action potential that allows the beat to be transmitted from one to the other. The channels are formed of proteins that are coded for by specific genes. And a channelopathy is an abnormality in the protein that forms or regulates the cardiac ion channel. And if you have an abnormality, it leads to a malfunction of the channels. If the channels don't work, the heartbeat can't be transmitted. If the channels don't work, the ions don't move in and out of the cell, the action potentials don't occur, and the heartbeat doesn't move from one cell to the next. So you get interruption in the heartbeat. And the channelopathies include long QT syndromes, and there are at least 15 types of long QT syndromes that have been described. Brugada syndrome, which I'll tell you a little more about in a minute, a condition called catecholaminergic polymorphic ventricular tachycardia, or for obvious reasons, CPVT for short. And the genetic mutations that occur, or the pathogenic variants that occur, may cause a loss of function in the way the channel works, and that's the explanation of how Brugada syndrome occurs, or a gain of function in the channel, and that accounts for the long QT syndromes. So back to Ms. V, based on the history and her electrophysiologic studies, she had been referred to us. Oh, wait a minute, I went the wrong way. So sorry about that. Although there are all of these different types of long QT syndrome, in fact, there are only 3 that are really common enough to really care about, unless you happen to have one of the really rare types. But there are 3 types that predominate and account for most of the individuals with long QT syndrome. They are long QT syndrome type 1, which, as I've already said, is associated with KCNQ1, which you'll all agree is a potassium channel mutation. KCNH2, which causes long QT syndrome type 2, and again is a potassium channel mutation, and SCN5A, which causes long QT syndrome type 3 if it's a gain of function mutation in the gene, or Brugada syndrome if it's a loss of function in the gene. And of course, SCN5A is a gene that encodes a protein that forms the sodium channel, because as we all know, the chemical symbol for sodium is S, which is not the case. I can't hear it, but I'm hoping that somebody's laughing. So the question really is, why do we require that medical students learn organic chemistry if we're not going to use the symbols, the chemical symbols for the chemicals for the elements that we're talking about? I don't know. Any case, all of the different types of long QT syndrome and Brugada syndrome are autosomal dominantly inherited. And of course, the significance of this is that if you find somebody who has long QT syndrome of any type, you need to test the parents of that person, the children of that person, and any first-degree relatives, because each of those individuals will have a 50% chance of also being affected with that channelopathy. So another problem is you can't distinguish one channelopathy from another on the basis of the presentation. All of them are associated with the same symptoms and signs: dizziness, syncope, palpitations, seizure-like activity, and sudden death. And sometimes sudden death can be the presenting symptom, unfortunately. So there may be no preceding episode of syncope or palpitations or anything like that. If the sudden death occurs before 1 year of age, we call it SIDS. If the sudden death occurs after 12 months of age, it's described as sudden unexpected death syndrome. So there are differences between SIDS and SUDS. Mainly the time of onset, but this is really important for any pediatrician to know. 20 to 30% of cases of SIDS will be associated with channel mutations. So it's essential in those cases, in any case of SIDS, that genetic testing be done, because that has implications for other children in the family and also for future children, as well as for the parents. You can see that on the other side, SUDS is more likely to be associated with an identifiable genetic etiology. But then after having said all this, what difference does it make which gene is involved? If you have long QT syndrome, you have long QT syndrome, and there are things that you need to do. You're at risk for sudden death. There are things we need to do to help prevent that from happening. Well, it turns out that specific variants leading to long QT syndrome have different triggers and different treatments. So it's imperative to identify the specific mutation, which will allow us to provide that individual with personalized care and treatment directed toward the genetic basis of their condition. So this is precision medicine. And here's an example of what I'm talking about. I'm not really making much sense, I think, but you can see this really clearly here. So at the bottom on the left is long QT syndrome type 1. And you can see that in long QT syndrome type 1, you're likely to die. If you have long QT syndrome type 1, you're likely to die while exercising. So these are individuals who are running up and down the basketball court and suddenly fall down dead. And they're dead. They can't be resuscitated. They get evaluated, and they have a potassium channel mutation associated with long QT syndrome type 1. Whereas those who have long QT syndrome type 2, the other potassium channelopathy, they don't have a significant problem with exercising, but they tend to die because of emotional distress. So they may get a phone call telling them that their friend who had long QT syndrome type 1 suddenly died while playing basketball, and they'll have a cardiac arrhythmia as a result of hearing that news. But even more weird than that is the fact that one of the things that triggers them having an arrhythmia is a startling loud noise. So these people can have a fatal arrhythmia when the phone rings, or when their alarm clock goes off, or when they're on, and this actually has happened in our clinic, on what's it called? A roller coaster. I'm sorry. So one of our patients had a fatal arrhythmia while riding on a roller coaster. This is characteristic of long QT syndrome type 2, whereas long QT syndrome type 3, the sodium channel disorder, is not associated with an increased risk in exercise, although there is an increased risk, but it's not the predominant cause, and not emotion or loud noises, but they tend to die in their sleep. And so knowing which type of long QT syndrome an individual has allows us to tailor make their treatment. So if you have long QT syndrome type 1, you get started on a beta blocker, the idea being that if you slow down the heart rate, you can prevent the onset of a fatal arrhythmia. And we advise them to avoid competitive sports. Whereas if you have long QT syndrome type 2, you also get started on a beta blocker, but we remove alarm clocks from their bedroom, and we remove auditory rings from their phone, and tell them to avoid loud noises as much as possible, which is hard in a place like New York City. And if you have long QT type 3, unfortunately, there's not anything we can really do about this. So they frequently will wind up getting a pacemaker or a defibrillator. And there's some argument about whether they should be on beta blockers or not. On this slide, it says mixilotine, but there's more recently evidence that they get started on beta blockers also. All of these different types, we should consider a defibrillator, an implantable cardiac defibrillator, which protects them from sudden death due to a fatal arrhythmia. It's important that they avoid the certain drugs that are known to prolong the QT interval. And there's a website that lists all of these called crediblemeds.org. And we ask them to check on Credible Meds before they take any medication. Anyway, so back to Miss V. We know that she had 2 sons, one age 6, who found her when she was lying on the floor of the bathroom, and a 4-year-old. So knowing that she had this autosomal dominantly inherited pathogenic variant, we contacted their father, who agreed to bring them for evaluation. And their initial evaluation, so just to go through this real quickly, before we see families, we review their medical records, we try to contact them beforehand and construct a 3-generation pedigree and assess the family's psychological state. When they come for their visit, we do vital signs and an ECG. We contract with the family, talking to them about what we would like to do during the visit, and more importantly, what they would like to do during the visit and what they'd like to get out of the visit. We do the history and pedigree if we hadn't done it beforehand. We do a quick clinical evaluation, including a physical exam. We do a social work assessment, and I'll come to that again in a minute. We review all the data, the electrophysiologic data, any genetic testing that's been done, and then we come up with a plan of what what kind of testing is indicated, if testing is indicated, and then we counsel the family all together, all in one room, 10 people in a room. It seems like it should be complete chaos, but it actually works pretty well because everybody kind of feeds into everybody else in the room. There's a special situation with a family like Miss V's, because the family has recently dealt with the loss of a loved one. The father is devastated. The two children are coming to grips with the fact that their mother is gone forever, and they need to be supported while they're going through the mourning process. But at the same time, it's essential that we test the children to try to find out if they're at risk too, because without question, it's a terrible tragedy for the mother to have lost her life because of this condition. But that tragedy will be compounded if we don't take the opportunity to test other family members, identify who else is at risk, and prevent them from having the same fate. So it's essential that we look at this and evaluate this, and we get them the kind of counseling that they need. In Miss V's case, we evaluated both of her sons at the clinic. They both had normal physical exams. They both had normal ECGs in the clinic, although in the essay that I wrote, they have abnormal ECGs. I just made that easier to start them on medication. We did family-specific genetic testing in both boys and found that they both had inherited the deleterious variant that had been found in their mother. And so we started them immediately on beta blockers, and we counseled their father about the need to restrict their ability to be involved in active sports that would cause their heart rate to go up. And we talked to them about using crediblemeds.org, and they come back for follow-up every 6 months. Thus far, it's been a few years now, they have done really well. They've bounced back after their mother's death. They haven't had any episodes of syncope or palpitations or any other complaints. It's clear that in Miss V, she had this variant that predisposed her to develop a fatal arrhythmia, but it took alcohol and cocaine to kind of tip her over the edge. So it was multifactorial. It was the genetic predisposition, but the environmental input that caused her to have the arrhythmia. So also on the first visit, we talked to the father about the importance of getting the kids not to use drugs, which I think is an important message to send to every kid. So I have 5 rules that I've developed through the years about who gets tested and who shouldn't get tested. So rule 1 is that initial DNA testing is only done on the proband. The proband is the person who, that's rule 2. Rule 2 is the proband is the person who has the disease. So in the V family, the proband was Miss V, and she got tested. So the proband is not necessarily the consultant. The consultant is the person who comes for evaluation. And in our case, the consultant was really the 2 children, but and we could test them because we had tested the proband already. But if we had not known what had caused Miss V's death, doing genetic testing was probably not indicated at that point. So that's rule 3. Rule 4 is when DNA from the proband is not available, the consultant can be tested with caution. Again, the reason for this is that if in the case of Miss V, she had died and and she had been one of the 50% of people who had long QT syndrome in whom no genetic marker could be found. That wasn't the case. The medical examiners also found a genetic marker, but if she had been one of those people in whom no genetic marker had been found, testing the boys would have made no sense, because if they were negative, we wouldn't know if they were still at risk to die suddenly or not, because clearly their mother had didn't have a genetic marker that we could look at that would tell us that they were at risk. Anyway, that's a little confusing, but we can test the consultant if the proband is not available, but we have to be cautious of what we say when we get the results. And in every case, DNA testing spreads from the proband, the person with the disease, to first degree relatives and then second degree relatives only when a mutation is found. So if we find, in the case of Miss V, we were able to identify a mutation in her, we could test the boys. We would test her siblings. She didn't have any siblings, so that wasn't possible. And her parents weren't available, so we couldn't test them. So the only people we could test in this case were the boys. So that's the end of that story, and I would stop here to have you ask questions if you wanted, but let's go on and we'll deal with questions at the end. And so this is case 3, Mr. S, and this story is also in the handout. So Mr. S was a 57-year-old man who came to see us because he had concerns about what he had been told at the hospital. And he told us this story. A few months before his visit to the clinic, he had been out for his usual Saturday morning 50-mile bike ride. So this guy lives in Westchester. He goes out every Saturday morning and rides his bike for 50 miles. This morning, it was August, and it was really hot and humid, and he was a fit non-smoker. He had been completely asymptomatic. He hadn't been sick at all. As I said, the day had been hot and humid, and he'd forgotten to bring his water bottle. And he rode about 5 miles and then stopped at a deli for breakfast, where he got a bacon, egg, and cheese sandwich on a roll with coffee. So he was fit, but he wasn't very nutritionally conscious, I guess. He then got back on his bike and he began riding again. And he developed some chest discomfort, which he described as the worst indigestion he'd ever had. So, but it was clearly in his chest and not in his abdomen. Within minutes, it resolved. About 15 minutes later, he was riding along through a village in Westchester, and he fell off his bike. He fell to the ground. His fall happened to have been witnessed by a passerby who happened to be an emergency room nurse, which is unbelievable to me, but it happened. And she saw him go down. She recognized that he was asystolic, and she started CPR in less than a minute. A second passerby called an ambulance. EMS came. They took over the CPR. They transported him to the local hospital, where he was found to have normal cardiac enzymes and a normal EKG. He was then transported to New York Presbyterian, where a cardiac cath disclosed that he had 85% blockage in 2 coronary arteries. Stents were placed in those 2 arteries. Also, a defibrillator, an implanted defibrillator was placed. So basically, it was like wearing a belt and suspenders to keep your pants up. They didn't know exactly what happened. They thought the coronary artery partial blockage was responsible, but maybe it wasn't responsible. So they put in the defibrillator just in case it happened again. And they discharged him with a diagnosis of silent MI. And again, he didn't like this. He had some questions about this. He had a bad family history. His mother had died at age 57 of which is the same age that he was, of what was touted as a heart attack, but no autopsy was done, so nobody really knew what the cause was. She had been in excellent health before that, and his brother had been told that he had some cardiac rhythm problem, but no information is available because 30 years before, I think around the time of their mother's death, he and his brother Mr. S and his brother had a terrible fight, a falling out, and they hadn't spoken since then. So we couldn't get any information from him. Also, Mr. S's son, who was 16 years old at the time of his visit to our clinic, had a history of fainting with blood draws. The first episode occurred when he was 2 weeks old. He had failed the newborn screen of hypothyroidism, and his pediatrician was drawing a sample of blood to send to the lab as follow-up. And he noted that the kid, when the needle hit the vein, the kid passed out at 2 weeks of age. And he's passed out every time he's had blood drawn since then. So Mr. S told us that since the defibrillator had been placed a few months before, he hadn't had any problems. There hadn't been any shocks. And our team agreed with his concern. And based on the history, we sent an arrhythmia panel to a commercial genetics lab. And lo and behold, they reported that he had a variant of uncertain significance in SCN5A, the sodium channel gene that's associated with both long QT syndrome type 3 and Brugada syndrome. So the lab noted that this variant of uncertain significance had been reported in 2 families with long QT syndrome type 3, but it also occurred in a segment of healthy volunteers. So it was present in the normal population as well. So this is the reason that you need geneticists, is interpreting whether a variant of uncertain significance is pathogenic, is disease causing or not. Unfortunately, most of the results that we are variants of uncertain significance. So we do this exercise all the time, and it drives all of us crazy. So how can you tell if a VUS is disease causing or not? So you can review the literature and see if it's ever been reported in an individual who has the disease that you're looking at. And in this case, you can see that it has been reported in a couple of families. But we also do an in silico analysis, which means we analyze whether it looks like this change in the gene is going to be is going to cause a change in the protein that results, and if that change in the protein is going to cause the protein not to function the way it's supposed to function. That's basically what it comes down to. And so we have a bunch of different ways of looking at that. In the case of Mr. S's variant, there was differing information. We couldn't ascertain on the basis of just looking at the confirmation of the protein that resulted from the variant, or the medical literature, or any of the other information that we had. So we were left with having to do what's called molecular phenotyping. And in molecular phenotyping, what we do is produce the protein in the lab that would result from this variant. And apparently it's not hard to do. Tom McDonald does it in his lab all the time. And what he found was, when he created the sodium channel that resulted from Mr. S's variant gene, he found that under normal circumstances, under standard conditions, the sodium channel worked fine. Everything looked perfect. But when he started fiddling with environmental differences in the environment in which the protein was being expressed, he found that when the pH dropped to about 7, so significant acidosis, the protein denatured and the sodium channel collapsed and it stopped working. So what we think happened with Mr. S was the perfect storm. He had a cardiac arrest as the result of a bunch of different things coming together that really almost killed him. So the variant of uncertain significance in SCN5A predisposed him to a lethal arrhythmia under acidotic conditions. And in his case, the acidosis was caused by his underlying coronary artery disease, which slowed the amount of blood that was going through his coronary arteries to his heart muscle, the vigorous exercise he was doing, which was throwing blood to his muscles, the heavy breakfast he had eaten while exercising, which caused blood to go to his splanchnic circulation to help with digestion of that stuff, and the relative dehydration that he had as a result of not drinking any water because he left his water bottle at home. So all of this came together to cause him to have the acidosis that led to the sodium channels to collapse and led to his cardiac arrest. That's really neat. I think, it's really interesting to be able to work all this out. But once again, so what? Who cares? So he has an ICD in. His management is not going to be affected by anything that we found. The issue is his son. So his son was 16 years old at the time that we did this. And he has he's the son of Mr. S, he has a 50% chance of having inherited the variant. Though he's in good health, he did have this history of syncope associated with blood draws. So were those vasovagal, which we all thought they were, or was that related to something associated with him having inherited his father's variant of uncertain significance? This is his work listed on this slide. He had echo, ECG, and EEG, which were all normal. And the diagnosis when he was evaluated when he was younger at New York Presbyterian was vasovagal syncope. So that's what they'd been told year after year, but we weren't so sure of that. We weren't certain. So we reevaluated him at Montefiore and really found that everything looked okay. His stress test was normal, but we told his parents that really, to be sure, we should do genetic testing on him. His parents declined testing. They said, he's been through so much already with his father having this sudden episode of sudden death from which he got better. We didn't want to stress him any further. So we didn't test him, but they promised to bring him back for follow-up every 6 months or every year to be checked out by the cardiologist. And if anything changed, they would call us. We were scared to death. There are ethical questions that are raised here. Should parents have the right to withhold this kind of information from their child? Basically, who owns the genetic information? Should a 16-year-old be able to decide about having a test that impacts his life? And if yes, at what age should children begin to be consulted? Is a 12-year-old able to decide, should an 8-year-old be part of this discussion? So these are all questions that need to be answered. But what's happened in genetics through the years is that the technology has run way ahead of the ethics. So we have the ability, the capability of doing all kinds of genetic testing, but whether we should be doing that testing or whether we shouldn't be doing that testing is open to question. And the question hasn't been answered. So we let this go on. He came back every year for a couple of years, but then he was leaving home for college. And I freaked out because I knew about a woman named Lauren Spearer. And some of you who live in Westchester may know this story. Lauren was a 20-year-old girl who lived in Westchester County. In June 2011, she was at Indiana University. It was the end of the school year. It was in May. She had finished her finals. She was out celebrating, and she disappeared. Nobody knows what happened to her. She has never been found. But she had long QT syndrome. She was taking a beta blocker. She wasn't a patient of ours, so I don't know I don't know her medical history. She disappeared, and she's never been seen again. I suspect that she was out, and like Mr. S or like Miss V, she had been using drugs. I'm not sure, but this makes sense to me. She had a fatal arrhythmia. Her friends who were out with her didn't know what to do, and they somehow hid her body somewhere and have never come clean about where she is. So Ricky, the son of Mr. S, is going off to college and does not know that he's likely to have long QT syndrome, or it's possible that he has long QT syndrome. Shouldn't he know this before he goes? His parents would not allow him to be tested. So getting to the end of the story, and I'm sorry I'm running over, for years after Mr. S testing, the S's declined even to inform their son of his risk. But he became engaged about 6 months ago now, and I finally got the call that I've been waiting for. He sought counseling, and he got tested for the familial variant that was present in his father, and testing revealed that he had not inherited the SCN5A from his father. So thankfully, the story ends with Mr. S because he's Ricky is an only child, and he's not affected. So we're not going to have to look at this in the future. So in summary, medical geneticists work at this interface between clinical medicine and molecular genetic research. And so hopefully through the presentation of a few cases, we've talked about some of the advances that have occurred in the field of precision medicine. And this is actually a slide from the medical students, so ignore that part. But this is really an important part. It's relevant to every field of medicine at this point. And as time passes, this will become more and more relevant in everyday practice. So I think that's the end. Again, I'm sorry I ran a little over. I guess I started a little late though. So happy to answer any questions or whatever. Fatima?
Well, I do have a question. Did
Yeah.
you happen to see there was an article, I think I read it on Apple News very early this morning, about 100,000 newborns being involved in whole genome sequencing, I think by a commercial company. So what are your
Yes.
thoughts on that?
Yeah, so this is really happening.
Yeah.
Again, the technology runs ahead of the ethics. We can do it, so it's going to get done. This has been a long history in newborn screening throughout the United States. Most states offered a small spectrum of testing, maybe a half dozen tests, and commercial labs started sending cards to pregnant women saying, if you send us blood from your kid and $300, we'll do this expanded newborn screen that will pick up 50 different disorders. So New York State responded by saying, you know what, we can't have a two-tiered system where some people can afford it and some can't. So we'll add that to our list. This is happening again. And that's why eventually, within a few years, we're going to get to whole genome sequencing as the as the test that is newborn screening, and it's going to be a mixed blessing, I think, is the best way to say it, because we're going to find out things we probably don't want to find out.
Right. Scary.
Yeah.
I think there were a few questions for you. I think Margaret's gonna handle that.
Okay.
Yep, I have the chat questions right here. Thank you so much, Dr. Marion, for presenting today. We really do appreciate it and definitely learned a lot. So our first question that we have is, you did mention ethical concerns with this testing, and I share those concerns. In an older 1997 movie, Gattaca, a young man is deemed genetically inferior and unable, without assuming another's DNA identity, to work in his chosen field. Although not currently happening, I do worry we will become a society of, in quotes, the genetically elite, and eugenics may be put into practice. Please comment on how we can prevent this.
It's a real concern. I think that all of us in genetics have, because again, the technology runs way ahead of the ethics, and we're going to have to set up some regulation for this to prevent what the bad things from happening. Really, and we have to do that right away. There have been efforts to give people choices about what they want to know and what they don't want to know as the result of, say, whole exome testing, which has been around for about 10 years now, and that works okay. We don't disclose information other than what we're looking for. But when we use this for newborn screening, we have to really closely regulate what information is going to be made available to anybody, including the family of the kid. Because, if you think about it, if you have a test that will tell that this child is going to go on to develop an adult onset neurodegenerative disease, as an example, and you have 3 kids and you only have enough money to send 2 kids to college, are you going to use that information to say, well, we're not going to send this kid to college because he's going to wind up developing some terrible disease anyway, so it's a waste of money? I mean, that's a stark example, but that's the kind of thing that can happen. So we need to be careful about regulating this from before the testing becomes available.
All right, thank you. The next question we have is, if I have a patient with, and I apologize if I pronounce any of this wrong, but with Brugada syndrome and says tested at cardio, but in quotes cleared, should they still have genetics done?
Yes. So, well, it's hard to say. I need more information about how they were diagnosed with Brugada, but if they truly have Brugada syndrome, a family history of Brugada syndrome, they need to be tested. The chance of finding a change in a gene that causes Brugada syndrome is actually very low. Brugada is a very strange condition. We don't really know what causes the majority of cases. we'll find that out as we start doing whole genome sequencing, because I think it's not in a gene, but it's in a regulatory region. We talk about this every week. We have a lot of patients with Brugada syndrome, and we have very few who are found to have mutations in one of the half dozen genes, 10 genes that are known to be associated with Brugada. So it's a good question, but we need more information. And whoever sent in that question can feel free to email me. I don't think you have my email address, but it's rmarion@montefiore.org. So feel free to email me about individual cases if you want. I love that stuff.
I'll be sure to put your email in the chat. Thank you for
Okay,
providing
good.
it for
Thank
us.
you.
Next-
I email you too often.
No, you don't.
Okay.
Not often enough.
Okay.
Next, we actually just had a comment. There's actually a couple doctors on the call who you taught. It looks like Dr. Marianne Edgehill said, "Hi, Dr. Marianne, great seeing you. I finished residency at Monty in 2006 with Benny, Liz, and Ryan." Someone else asked, someone said, "This was amazing. Thanks so much." They asked for your email. Like I said, I will provide that. They do have a specific case question though. They said mom's sudden death at age 42, dilated cardiomyopathy, trying to understand child's genetic results.
Good. I can help with that.
Okay, thank you. And then one other question we have are, what are your thoughts on 23andMe?
So I don't think that you get more information except in certain circumstances. I think you get as much information by around the Thanksgiving table, taking a careful family tree as you would in spending all the money for 23andMe. Sometimes the results make things worse. Sometimes the reason, because they send you on a wild goose chase. We've had patients who have gotten erroneous results from 23andMe that have come to us and been hysterical, and we've had to calm them down because the results were not accurate. And on the other hand, you know, at the end of the day, you find out that your ancestors are who your ancestors are. And unless there's like a question, I mean, you hear about people who find out that their fathers were not their fathers, the person that they thought was their father was not their father, and that they have this whole other family. Those are pretty rare, but it's helpful in getting that information, I think, for a lot of reasons. But under normal circumstances, it's not, you know, you can get more information by just talking to your grandparents, I think.
Great, thank you. Does anyone else have any questions that are not in the chat yet?
Okay, so
Okay.
that concludes our presentation. I'd like to remind you again to gain your CME, please respond to the link from the email that will be sent to you for all registered individuals for tonight's meeting. Dr. Marion, this was absolutely an amazing lecture, and the amount of questions on top of everything else, the ethical issues really clearly are certainly apparent, and it's going to be hard to answer them, you know, very hard to answer them. We'd like to thank you. Hopefully we can invite you back in the coming year and to get follow-up to this.
Great.
So thank you
Well,
again.
thank you very much for inviting me, and I really enjoyed speaking with you.
Thank you.
Thank you and good night.